Our first speaker tonight is Professor Alan Cheng. Alan is an infectious diseases physician based at Alfred Health and Monash University. He is involved in hospital infection prevention and control, influenza surveillance, and public health policy for vaccine-preventable diseases. I sure hope COVID-19 is one of those. Currently, he's an invited expert on several government advisory committees responding to COVID-19. I look forward to hearing an insider's perspective from him. Please welcome Alan.
Thanks very much, Damien. I will share my screen. Okay, just checking that you can see that and you can hear me okay, Dan?
Yes, I can see it.
Okay. So I'm Alan Cheng. I can't tell you how intimidating it is to stand up in front of 160 something statisticians as not really a statistician. I'm an infectious diseases physician and a hospital epidemiologist by training. I have had some experience with modelling and a background in public health and a master's of statistics, but by no means am I an academic statistician. So just to make it clear that I do sit on government committees, but the opinions that I express may not represent the views of committees or government. So what I'm going to talk about is it's going to be a very technical-free, formula-free talk. I'm talking mainly about public health policy, but also just in general how models have been used to shape government policy. Some models not from Australia that are probably not so helpful, and just how what good models and bad models look like. And then where things are going, what will help now, and what are the sort of things that we will need next. So I do have to acknowledge that Freya, who's going to follow me, and her team, which include Jodie McVernon and James McCaw, have led all the modelling. This is not my work. And they are part of a global consortium of modellers coordinated by WHO. So some of the questions that have been answered are about travellers and the effect of travel restrictions, obviously less important now that we have a travel restriction on everyone. And then what would an unmitigated outbreak look like, and why do we need to do things to control this infection? What could isolation and quarantine by itself work alone? And then how much supplies, PPE, ICU beds and so on might we require? And then how effective are the public health interventions that we've put in place? So Freya will talk about the importation model, but just to highlight that one important contribution of this was not just to worry about the countries where it seemed to have a lot of cases, but also to worry about the countries that didn't report a lot of cases. So it's sort of counterintuitive to say that, you know, should we list countries as high risk even though they didn't have many cases based on modelling. And I'll let Freya talk about this in her talk. In terms of transmission models, so these have been around since 1927, so there's nothing new here. And the models that have been used are deterministic compartmental models with random sampling for the main parameters of note. You can see here that this is a standard SEIR model. The double compartments for exposure and infection are really just a mathematical trick to get a different distribution of progression between the compartments. And then the variants here are to introduce some compartments for isolation of cases once they are detected and regard them as less infective, and then for quarantine of close contacts to regard also them as less infective if they progress to infection. And then built onto this is a model of care model that of the people that become unwell, how might they progress through the healthcare system based on their severity, where they present, and then their risk of hospitalisation, which is age stratified, and then the risk of critical illness. Even though deaths is in this model, it's not really so much of a public. This is about the place where people get treated rather than deaths alone, but obviously it is an output of the model. And so what this has shown, and this has probably been seen by most people, is that this is a model of ICU demand. The percentiles represent some of the distributional, the distributions from which the parameters are drawn. And what this did suggest was that a very unmitigated scenario would very quickly overwhelm our health system. So, you know, this is incidence per day per million population. So if you multiply that by 25, you get the number of ICU admissions per day in Australia, which would be in the order of several thousand a day. And we have about 2,000 intensive care beds in the system. So you can see very quickly that an unmitigated scenario would be catastrophic. Even with isolation and quarantine, there still would be quite a significant outbreak, which suggests that we need to do more than just public health follow-up. And obviously, this is just a scenario. We could easily overwhelm isolation and quarantine, so it may not, you know, this is a possibility, not a prediction, but it does say that we probably need to do more than isolate and quarantine patients. In terms of unhelpful models, this is one that's been used quite a lot in the US, but if you sort of dig into the how the model is created, it's basically a statistical model where they just assume that the epidemic curve is normally distributed, which is sort of an odd way of looking at this, particularly that we actually know what the dynamics of an epidemic should look like. And this gives us sort of very odd sort of properties. And so this is an output from a few weeks ago from this model. And I don't think you need to be a statistician to realize that you probably have more certainty about what's going to happen next week than you're going to have in June. So a prediction of between 20,000 and 200,000 beds being used is probably not all that helpful and not probably that realistic either. In terms of what's happening at the moment, there's an attempt to estimate the effective reproduction number and then some effort into near-term forecasting to work out what we might be able to do in terms of hospital services. There's work looking at the ascertainment fraction based on case fatality ratios and so on. And then possibly what the endgame might look like in terms of elimination or suppression, recognizing there are a lot of stochastic effects there, and the distribution of transmissibility, so the distribution of the reproductive ratio is important there. So this is recent work. Again, Freya has contributed to this with David Price and James McCaw. Looking at what looks like the observed growth in cases in different states, and interestingly, what you can see is that the little surge in cases in Tasmania in the North West Regional Hospital is visible on this, and one of the odd properties of this is now that we have very small numbers, there is obviously a lot of uncertainty in the credible interval, but it probably does pick up any little blips that might occur. So in terms of the key unknowns from here is, well, obviously the vaccine is probably going to be very important to this, but and then you know, the timeline for that is uncertain. We're still progressing through phase 1 and preclinical studies for most vaccines. But a key question will be, well, how effective is it? You know, a lot of viral vaccines aren't particularly effective, like influenza being about 50% effective. And then if we had one, how would we actually deploy it? So that's going to need some modeling to work out the best deployment strategy. There's a lot of work going into at the moment to look at how much transmission might be occurring and how much mightn't be detected. And this is done by looking at observed case fatality ratios and trying to estimate how much is going on out there. A key question is immunity. If they're after infection, how much immunity is there, or what is the degree of protection, and how long does it last for, and how might that impact our control policies? Obviously, treatments are an important question. It'd be fair to say that most treatments are generally better when employed earlier, and a good treatment would reduce mortality by 10 or 20%. So it's probably not going to be a cure or any sort of miracle against this sort of severe infection, but it will be important to have one and know exactly how we should be using it. Key question that's dominating thinking, particularly at jurisdictions at the moment, is health system capacity. Initially, we war gamed against very severe catastrophic scenarios, but now that we know that it is possible to control COVID, so all the things that we're doing probably have brought it under control. Exactly what is it that we will need? Well, is there still a possibility that we'll lose control, but perhaps at a lower reproductive ratio? How much is it that what are we now preparing for? And there is certainly a concern that there are a lot of impacts on health outside of COVID. So putting off preventive health, primary health care, people not turning up with strokes and acute myocardial infarctions is also going to have a major impact on health now and in the future. So how can we best open up our health services without risking a breach in capacity down the track? And then more broadly than health, there's a lot of questions around the impact on communities. So clearly a lot of the interventions that have been put into place have put a lot of people out of work. The compliance with these may well wane with time and may not be sustainable. And how best can we mitigate some of these impacts without risking a loss of control? And then finally, all of this, the burden of who bears these burdens is very important. And how do we protect vulnerable populations, not only from COVID, but also from the control measures that we're putting in place to try and control this as well. So to summarize, I think modelling is only one input of many considerations that go into decision making. To misuse a phrase, all models are wrong, but some of them aren't even very useful. And the value, I think, of modelling is often in explaining things that are counterintuitive. I think in terms of trying to explain models, and this goes with statistics as well as epidemiological modelling, it does seem to be a black box, and there are really often two reactions to seeing a model. There's the first is I don't understand it and I don't believe it, and there's the second one is I don't understand it, so it must be true. It's very, very difficult to convey limitations and assumptions to policymakers who may not understand the underlying assumptions all that well. And probably a very good example of this is when people look at models that consider school closure or school dismissal as an intervention, that clearly is very sensitive to whatever assumption you make about transmissibility in children. So if you assume that children transmit as well as adults, then of course closing schools will have an effect. If you assume that they don't, then they won't. So it's very easy to confuse the output of a model with the inputs that go into them. The other issue is sometimes that people think that they are predictions, and the first reaction to an unmitigated scenario is to say, well, we've got to go and find 70,021 intensive care beds, where that's clearly not going to be the case, and they really are just tools to model what might happen given those assumptions, and very precise numbers do give an illusion of certainty, which often isn't there. So in terms of future questions, there's, well, what's going to happen next, and in terms of the control of COVID, but also the impact on non-COVID health, the broader impacts on society. I haven't really talked about things outside of Australia, but low and middle income countries with weaker health systems and weaker public health systems will be really important. And then the questions about vaccine. So in terms of what's next for COVID, we are moving into the next phase of this, and there are decisions to be made about are we going for a temporary elimination or a sort of a better, sort of a more intense suppression strategy, or are we just trying to control things as they are at the moment? So there is a phase at the moment of trying to just get some of the tools into place. So surveillance systems to make sure that we have good situational awareness, not just of cases, but all the other things that need to go along with that. You know, do we have good situational awareness about what's happening in our hospitals, in our primary care, and with ventilators and personal protective equipment and so on. The second piece of work is around public health capacity and making sure that whatever comes, we have the capacity to respond to that. So public health units have scaled up their contact tracing from 20 to 30 people up to 1,000 people in most jurisdictions. So they're all going to need to be trained and ready for whatever might come. Health services have all tooled up, so we're trying to make sure that we have enough personal protective equipment and ventilators and models of care that can cope with whatever comes, particularly if control efforts slip. And then some monitoring of what the public think about all of this and adherence to some of these measures. And then with all of those in place, there is the signal for the potential for some restrictions. I just thought I'd sort of finish with this because I think there was a lot of chatter on the statistical ANSTAT list about should we do a population sample to look for asymptomatic infection, and I just thought I'd discuss some of those issues. So the first thing is that there are two types of tests. There's serology that looks for exposure, meaning cumulative incidence, versus PCR, which active samples for active infection, and that stays positive for probably about 7 to 10 days. We do actually know that asymptomatic infection probably isn't that common. So there are, outbreaks in closed community settings and even some smaller communities, such as in Italy, where they just have sampled as many people as they can. And we aren't really finding missing links in transmission chains. So if there was true asymptomatic infection and transmission, we would expect to see a lot of broken transmission chains. It doesn't exclude the possibility of pre-symptomatic transmission, so that the link becomes visible after the transmission has occurred, but it probably means that true asymptomatic infection isn't that common. And there are a few serosurveys coming out of varying quality, but they're not finding a huge seroprevalence, more than we would expect, given the cases that we've found. If we were to look for asymptomatic infection in the general community, sort of these back of the envelope calculations would suggest that it probably is not that common at the moment. We're only detecting 10 to 20 cases in Australia at the moment, and the duration of PCR positivity is 10 days. So even if there was 10 asymptomatic cases for every case, we'd still be looking for 1 in 25,000 group, and this would be heterogeneously distributed. And then finally, when you're looking for things that are that rare, there's always the issue of false positives, which aren't clearly very common, but they are very highly consequential. They do result in people being taken off work and their family being quarantined, and often businesses having to shut down with cases detected. So you clearly don't want a false positive. And then finally, we probably haven't optimized all testing of symptomatic people at this stage. There are probably still symptomatic people out there that are not coming forward for testing for whatever reason. For example, casual workers have a very big disincentive to be tested, or they'll either lose their job or lose their income. That's not to say that there isn't a role for testing asymptomatic people at all, particularly in outbreaks. It's going to be important, and serosurveys are pending. So I'm going to stop there and hand over to Freya.
So thanks, Alan. I might just introduce Freya. Before we do that, I'm sure there are plenty of questions out there. If you have questions, I would like you to write your question into the Q&A feature of the Zoom webinar. So if you look either at the top or at the bottom of your window, you'll see a button Q&A. Just put your question in there. I can see there's already a number of questions that people have put in. If you like any of those, you can upvote those. That'll help us prioritize them at the end of the talk. Okay, so I would like to go on to the next speaker now. Our next speaker is Dr. Freya Shearer. Freya is a research fellow at the Melbourne School of Population and Global Health at the University of Melbourne. Her primary research interest is in the use of models of infectious disease as tools for public health decision-making. She's currently part of the modelling team supporting the Australian government response to COVID-19. I look forward to hearing some more details about her modelling. Please welcome Freya.
Thanks, Simon. I'm just going to share my screen, hopefully. I think that might be the wrong one, actually. Let me try again. Can you just confirm you can see my slides?
Yes, I can see your slides, Freya.
Great. Okay, so I'm going to be talking about today about modelling to assess COVID-19 risk to Australia and our region, and in February 2020. So this was an analysis that was relevant during the very early stage of the outbreak in Australia. So this is an early timeline of the Australian epidemic. So it's showing from mid-January through to the 14th of April. So the overseas acquired cases are shown in purple, locally acquired cases in blue, and those without where the place of acquisition is unknown is shown in green. And then also plotted on this figure is the key border measures and social distancing measures implemented over time. And so for this talk, I'm going to be focused on an analysis that was used during, basically during the month of February. So at this time, Australia banned travel from mainland China to Australia on the 1st of February. And so only Australian residents and citizens could travel from mainland China to Australia and their dependents. And upon arrival in Australia, they were required to quarantine for 14 days. And at this time, well, actually the day before these travel restrictions were imposed, there had been 9,720 confirmed cases in China, 106 cases outside of China. And of those cases, 79 were in the Southeast Asia and Western Pacific region. And of those, 9 were detected and managed in Australia. So also in early Feb, a number of prebrints relevant to spread outside of China appeared. This is one of them. So this group estimated importation risk from Wuhan to other cities in China. That's on the left panel, and the right panel, importation risk from Wuhan to other countries. And here they've just plotted their importation risk metric against the number of cases that were reported to show that they were correlated somewhat. And they also published a list of the countries at highest risk of importation to highest risk of importation risk of COVID-19. And in that list of top 30 countries was Australia, along with lots of other countries in the Asia Pacific region. This was another preprint that was published around that time in early Feb. And they used a very simple model to predict the expected number of cases and to potentially model under detection. So here they simply assumed that the expected number of imported cases was linearly proportional to the air travel volumes. And they used a bootstrapping method to produce a 95% confidence interval. And they suggested that those countries that were below the lower bound of that confidence interval may have undetected cases. And 3 countries, Indonesia, Cambodia, and Thailand, were implicated, and they're obviously in our region and highly connected to Australia. So in early Feb, Australia had banned travel from mainland China. there was concerns that many countries in our region were still at very high importation risk of COVID-19, that Australia was highly connected to those countries, and that there was a possibility that there was undetected cases in the region. So there was a need for analytical risk assessment to determine what the risk of importation was to countries in our region, and then the subsequent importation risk to Australia. So we developed a risk assessment framework that was used to identify which symptomatic individuals presenting to healthcare should be tested for COVID-19. So that's a retrospective with a retrospective travel history. To inform DFAT travel advisories, to update the epidemiological case definition, and also to provide support to other countries in our region. So the framework was developed to assess the risk of COVID-19 spread in our region to Australia during the early phase of the outbreak, so up until around late February, when China was the only country reporting uncontained transmission. Travel restrictions were in place from mainland China to Australia, and China was primary importation risk to countries in our region. So the primary concern for Australia at this time was the epidemic status of countries in our region. So if you look at the framework schematic shown here, so the source country was China. Country of interest in this case is Australia, but you could also apply this to another country, such as a country in our region. And we looked at the importation. We had a set of intermediary countries, and we looked at the importation risk from China to these countries, the number of potentially undetected cases, the probability of an outbreak occurring, outbreak size, and then understanding at any given point in time the size of the outbreak in these countries, and then the subsequent importation risk to Australia, and use this to estimate the probability or the timing of sustained transmission. So the intermediary countries that we focused on were those in the Asia Pacific region, because they're very highly connected to both Australia and China relative to other parts of the world. So for steps 1 and 5 of this framework, we mainly used travel data. Step 2, to determine possibility that there was undetected cases, a very, very simple statistical model. That was that de Salazar model I showed earlier. And for the probability that an outbreak occurred, we used a branching process model, which is just a type of epidemiological model that we can use to simulate early epidemic dynamics. And that was developed by colleagues at the University of Adelaide, Andrew Black and James Walker. And we used the same branching process model to determine the probability of sustained transmission in Australia as well. So we developed a set of summary tables that displayed quantities estimated at each step of the process. So if you look at this table here, it's showing quantities estimated at steps 1, 2, and 5. And the reason for this was we wanted to show decision makers the logic of arriving, say, at this the final metric that we were estimating, how we arrived at that point, and somewhat allow them to come to their own conclusions by assessing information in these tables. And so here you can see travel volume from China. Oh, the coloured shading as well is relative risk. So higher risk is red, lower risk green. You can see that the expected imported cases is proportional to the air travel volume from China. We're also reporting connectivity between each of these countries and Australia, and the number of reported cases. And if you look at the expected imported cases against the reported imported cases, it gives you a sense of what's possibly not being detected. And so this graph here is showing you from left to right potentially undetected cases in the region as of February 19, with the highest number of undetected cases here on the left through to the right there with Singapore estimated to be 0. And then we use these undetected cases to estimate the probability of an outbreak occurring. So we assume that undetected cases are more likely to contribute to onward transmission. And then we can estimate outbreak size over time based on the number of undetected cases. So this is an example of where we would have a low expectation of sustained transmission in a country. So if you look at the plot here on the left, so the red line or pink line is the expected number of imported cases, and the black dots is the number of reported imported cases. In this situation, because the expected number of imported cases aligns with the reported cases, we have a low expectation of sustained transmission, and this location they're reporting a low number of above 0 local cases at that point. This is an example of where we might have a high expectation of sustained transmission. So in this case, we're expecting the expected number of imported cases, again shown in the pink line, but no imported cases have been reported. And so in our case, we have a high expectation that there's local transmission is occurring, and it's just not being reported. So we can do these calculations for all of the countries of interest, and then use the information about likely epidemic growth or likely incidence over time to estimate the probability of importation risk to Australia and the probability of sustained transmission. So again, we used a combination of travel volumes and a branching process model to estimate the timing of sustained transmission. So this plot here is showing, so we have time on the x-axis, and this is shown in weekly increments. The coloured squares is the probability of sustained transmission, and plotted above here is the ratio of local to imported cases per week. So if we're below this line, there's a higher proportion of imported cases, and once we're above the line, we're expecting a higher proportion of local cases. And you can see here that when you have nearly half of the cases are local cases, there's already a very high probability that of sustained transmission, and you've arguably already lost control at that point. So that was step 6 of this framework that was being used at that time, and I'm gonna stop there and go for questions. I just want to acknowledge colleagues at the University of Melbourne and the University of Adelaide who've been involved in this work, or other work that we've been doing over the course of the last 3 months or so. Thank you very much.
Thank you, Freya. So at this point, we can move to question time. Now I see there's plenty of questions that are asked, have already been asked. If you have a question and you haven't put it up there already, go to the Q&A window and write your question in, or if someone's already asked it, click the thumbs up to give it an upvote and we can get to your question. Alan, I noticed that you've been answering some questions already. Just for the benefit of everyone who's listening in, I think it's best if we do this live via voice.
Yeah,
so we might go back to some of those already so that anyone who's missed on the window can benefit from the answers as well. So just to start with, I'll take the ones that are still open and I'll go from the top, and then we'll might skip back and forth depending on depending on priority, which I'll determine as we go. But let's start with the first one. This is a question from Luke. A very interesting talk. How do you account for problems with the data collected? You gave the example of not everybody who is symptomatic will choose to be tested. Another problem is people may be more likely to be tested on weekdays than weekends. Do you assume the data is accurately measured, or do you allow for measurement error? Who would like to take this question?
Freya, you across that detail?
Well, I was going to say it's given that so in terms of data, none of the analysis I think we've presented in these talks has been using data like that. So yes, we can definitely account for measurement errors and think about things like that when we're developing models that use that type of data, for sure.
I do know that with estimation of things like R0 and things like that, the major issues come where there's a change in the severity, for example, or the detection fraction in patients. So that I know that was an early issue in China, where obviously the test only became available, and then you sort of suddenly detect a whole lot of people, and then you often start at, you know, detecting more severe cases, and then you work your way down to sort of find all the other mild cases. So those sorts of issues can become really important. But if you, for example, have a good feed of hospitalizations, and you know that all hospitalizations are probably about the same severity, it becomes less of an issue.
Okay, I might just skip between the two windows to just to highlight. I know, Alan, you may have already written something, but just for the benefit of everyone, just to give a bit of a comment. So there was a question about how would you compare the way the government has handled the pandemic in Sweden versus other countries? And I won't read out the whole question, but do you want to?
Yeah, so Sweden has taken a very different approach to Australia, and they've allowed the they've imposed far less restrictions. Some of that is because I understand of legal reasons. There are, you know, only so many powers that they give the Swedish government to actually do. But other, I think, is a philosophical issue about, you know, trying to let the infection spread in the general community while trying to protect, you know, the most vulnerable. I think it's always really difficult to know. We're at an early stage. There's, you know, Sweden does have quite a lot of deaths compared to Australia. So I think we have, you know, about 100 and something, and Sweden has 2,000. But it's still really early days, and I think it would be an error to say that, to claim victory and say we're doing really well. We're, you know, there's months and months and possibly years to run. Sweden is also in a very different position, that they have land borders and free movement with Europe, which puts them in a very different situation to Australia, where we, you know, you can only arrive by land or sea, which is much easier to control in Australia. So that would be the same situation as Canada. You know, we would be in a very different situation if there was another very large country with uncontrolled epidemic and a large land border with us. So every country, I think, is trying to work out what's its strengths and weaknesses, and do what we can.
So we have a question from Pete here. So can we model to find the optimal balance between the prevention of COVID-related negative health outcomes and prevention of non-COVID related negative health outcomes due to public health measures in place? So like employment, social cohesion, and that sort of thing.
Yeah, in theory, it would be possible. It would clearly be a very complex multidisciplinary model looking at COVID and non-COVID. But I think a lot of the tools that we have are probably not that sophisticated that we can do that easily. Trying to model the, you know, negative health outcomes of things like employment would be relatively difficult, and we probably don't have a lot of data. I think it'd also be fair to say that you know, the consequences of an unmitigated outbreak are so great that they sort of overwhelm every other health outcome. But whether there's sort of some balance in between that could be found, I think, is probably a good question, and probably not easily answerable.
I'm going to insert my own question there, just to follow on. I'm wondering if you can tell us more about how you actually interact with the policymakers, because they're having to do exactly that sort of trade-off in their heads. And you and Freya are able to provide them with sophisticated mathematical justifications, or at least explorations of various things. But you know, it's just one part of the equation. So can you just paint the picture of how, you know, what's going on in that communication to them, and maybe what they're thinking?
Yeah, so maybe I'd just sort of give an explanation of how the sort of advice structure works. So there are sort of some major committees. So there's technical committees. So one's called the Communicable Diseases Network of Australia, which is the leads of communicable diseases control. And so that's often the committee that will decide on, you know, what are the correct criteria that we test people by. You know, what do we do when we find someone? How long do they need to be in quarantine? All those sort of very technical questions go to that committee. And sitting alongside that is the Public Health, PHLN, the Public Health Laboratory Network, which sort of answers very technical questions about, you know, what tests do we use and how good are they and what do we need to do to, you know, make them better and that sort of thing. Then those two committees answer to or report to AHPPC, which is the Australian Health Protection Principle Committee, and that's the one with Brendan Murphy, the Chief Medical Officer, and then all the state Chief Health Officers. And that's where advice is given from that to say, this is, from a health point of view, this is what we would do to protect the health of Australians and control this outbreak. So it's sort of based on technical advice from CDNA, and then that advice goes up to National Cabinet at the moment, but in a normal time, it would be the National Security Committee. So the National Security Committee, or National Cabinet at the moment, is the one that has all the other people around the table. So the economists and the education people and the DFAT and all those people to say, okay, this is the health lens, and the health lens clearly early is dominating, but all the other voices are around the table there. So I don't sit on that committee, so I don't know exactly how that discussion goes, but they're the ones that have to work out, you know, how much do we have to pay job seeker payments and all those sorts of things to mitigate all of this. So all those voices come into decision making. The voices that, you know, we have privy to are mainly the ones that look at health. So, you know, looking at social cohesion and those sorts of things is really the domain of the politicians, even though the jurisdictions have to implement it. And then finally, just, I don't think this is news to anyone, but the National Cabinet may decide something, but actually it's the states that actually do stuff. So we are a federation of 8 governments and a Commonwealth government, and in the end, whatever is decided at National Cabinet has to go back down to each of the state and territory governments to, you know, decide whether to open schools, which obviously is a contentious decision at the moment, but all the other things that are done have to be the public health responses, everything else goes down there. So it is a complicated system of government that we have, but I hope that sort of gives a bit of insight to how this all fits together.
Yes, thanks. So we have a question from Pete Markey. So the age-based hospitalisation rate for COVID in Australia seems to be much lower than in other countries. How do you interpret this and use these inputs for models?
Freya, do you want to take that one?
So yeah, we can use our we can estimate those quantities from our own data now. So we have enough information to use those as inputs into models. Early on, before there was many cases in Australia, we were definitely relying on international data to inform those. So those scenario models that Alan presented had in his presentation, for example, that modelling had to be done with information from overseas, but now we can use informed models with information that's specific to the Australian epidemic. Sorry, I can't hear you. I think you're on mute.
Indeed, I was, sorry. My kids have just left the room, so I can probably not stop doing that. Do you have any comments about comparisons to other countries?
Well, clearly, yeah. Look, clearly the the hospital in the sort of reported infection to hospitalisation ratio is very dependent on testing policy. So the US and the UK, which are basically only testing people if they come to hospital and a few other people, it's going to look a lot higher than it is in Australia. And that, in fact, that's how some of the the estimates of case ascertainment are made from that sort of ratio.
And I'll just say the other thing that sort of has impacted some of that is early on, some people were hospitalised for public health reasons rather than for clinical reasons, and that may have skewed things in some countries as well.
So I see there was a question from John Carlin earlier on. So the estimates of RF after the fact suggest that the value of this key parameter was quite a lot lower in Australia than the value of 2.53, which is based on the Wuhan data that was used in the initial modelling, even before any significant control measures were put in place. So clearly there was a lot of uncertainty at the time, and it was probably prudent to err on the side of caution. But in hindsight, isn't it possible that somewhat less restrictive measures would have worked almost as well?
Yes. I mean, I think that the relationship between what we think will help and what actually happens is not very clear. So, there's all sorts of things are done, and then you're not entirely sure which of it has actually worked. And I don't think that's easily modelled. We haven't used, some of these public health powers for more than a century, and what people will actually do and accept is clearly difficult to estimate before you do them. I think the other thing I would say, though, is that if we brought, the effective R down to 1, that means that we would have just kept the same number of cases going. And what we're really trying to do was really trying to get it below that so that we could get cases down to where we are now. So I think more by luck than by design, we're in a pretty good position, having sort of brought the numbers down. And now the question is, what can we actually relax without getting a surge in cases, sort of keeping R around 1 or closer to 1, at least to now. And I think the worry is that, despite everything, all the restrictions and putting a million people or several million people out of jobs, we're not that much below 1. So it's difficult to know how much we can relax things without risking everything blowing up again. And yes, I do acknowledge that there are impacts beyond COVID that are probably going to be really important, and they will become more and more important as time goes on. But it's, there are no easy decisions here.
So I've got a question from Ben who hasn't been able to use the Q&A window. Perhaps because you're one of the co-hosts, I'm not sure if that's how it works. Anyway, this question is a great one because it relates to society too. So, and it echoes something you said at the AGM last month, Alan. So the question is, there's been a rise in armchair epidemiology with people from various data modeling backgrounds having a go at modeling COVID-19. How much of an issue is this in trying to communicate your own results? And does this impact on communicating to policymakers?
I might answer this first, and then I might let you, Freya, answer it as well. But I think it's a difficult one. I think, it's clearly good to have a lot of interest in epidemiology, and there are commentators out there who are very intelligent and finding things in the data which are quite useful. But there are also a lot of people that seem to be pushing analyses to fulfill a worldview or something that for more nefarious purposes. And I think it's pretty difficult to sort of cut through noise when it's clearly a question of there's a lot of interest and a lot of people trying to comment on things at the moment. I mean, I think that's just a reality. I don't think, it's not that, I'm going to say that there's one model to rule them all, and everyone just needs to listen to that. That's clearly not the sort of world we live in. But there are, I think, as I said, all models are wrong, but some of them aren't even useful. And I think that there are a lot of people calling for things that may not be very evidence-based, based on dubious modelling. And even in the scientific literature, a lot of all the preprints that are going out, some of them are pretty average quality and are probably not helpful. But I guess that's science, and I think, as I said somewhere else, it's pretty breathtaking to see science proceed in real time when good and bad theories get thrown up, and some of them survive and swim, and some of them don't. And I think it's important. And it's a difficult time to be trying to communicate science, that's for sure. Freya, do you want to comment on?
Yeah, I think just a couple, like sort of, and what Alan said really covers it. But I think a couple of things to add is that sort of infectious disease modelling is a really interdisciplinary field, and there's people of lots and lots of different backgrounds, and that makes it very interesting. And it also and I think, like, there's a lot of there's a strength in people looking at problems with slightly different training as well, which is actually as sort of can move the field forward as well. So I think it's good to sort of pay attention to some of these things that come up. And I also was going to say that the communication is and it has made communication it can be difficult, but I think that's just the nature of science. And I think when you have a big problem, you have lots of people wanting to contribute, and I think that's just normal and something that we just haven't had to navigate before. But we also haven't had experienced an event like this before either. So
I do have to say that it is impressive to see, some of these pretty obscure modelling concepts and things, hit the front page of the paper, and having, the Prime Minister quote reproductive numbers in a press release, I think is pretty unprecedented. And it is really interesting to see non-technical people explain sometimes very complicated things very well, actually. It's pretty impressive. I think I said this somewhere else, but Angela Merkel explaining, R0 and its impact on the German healthcare system is about as impressive as it gets for a non-technical person. And I know she's very clever, but it is still pretty impressive to be able to explain to the public.
And I would also say that there's multiple modelling approaches to any given question as well. So, and I think that it's important to keep that in mind, because, and certainly policymakers in Australia are doing that. So, as Alan says, there's not one model that can answer all questions or is the best one to answer any given question.
Great. Well, we have a question from Anthony. In hindsight, would including European and North American countries in the model have been valuable?
I assume that's probably applying to Freya's.
Yeah, the risk assessment. The risk assessment. So I would say in hindsight, yes. And I think we kind of, when sort of towards mid to late February, as transmission, there was clearly lots of transmission in some other in countries outside the region. That's when it became clear that the limitations of this framework, and there was definitely a switch point where we switched and we're thinking about in a completely different way. So it sort of had it was for a specific purpose at a specific time. And also the other thing is we probably had expectations about some countries being more equipped to detect cases earlier, such as the US. So yeah, certainly.
Alan, did you want to add anything, or is?
Yeah, I think I do remember at a meeting, Jody saying, you know, we can model the risk from maybe a dozen extra countries, but you have to tell us what those dozen extra countries you want us to model are. We can't do 192 countries in a model.
Yeah, it certainly became,
brains would melt down.
yeah, it certainly became, once we were in a pandemic and the risk was everywhere, it was a different question.
Yeah.
Different process.
Okay, so, we have a question from Penny Robinson, who asks, South Korea and US had their first case on the same day. So can someone comment on the pandemic in the US, I guess, in comparison to South Korea? Do either of you have a comment?
Yeah, so clearly it's not going very well in the US, and it's going much better in South Korea. And I think there's a number of reasons for that. And you know, most proximately, it's sort of the ability to test and detect cases, and you know, awareness, and South Korea having had the experience of SARS in the past. And then there are lots of upstream factors, and clearly the governance of the US is a little unusual at the moment, and I'm sure that's had to it. So I'm sure there are going to be people that are writing PhDs about this for well into the future. But they do. There are a lot of contrasts, and I think there are a lot of, you know, things that we can learn from other countries that are both doing well and not so well. So I think, you know, as soon as Singapore detected cases in their foreign worker dormitories, you know, the first thought is, well, what is our, you know, Australian equivalent of that? And, you know, it might be mining communities or remote, you know, remote Indigenous communities and things like that. So, you know, we all have our vulnerabilities, and this virus is finding each country's vulnerability, I think.
Okay, we have a question from Carlos, who asks, where can we learn more about the models and analyses you have done? Would you share a list of publications or resources? I see someone's already posted a set of links up there.
That's a trustworthy, yes, that's David Price posting those links, and that would be the place to go.
Excellent. So if anyone can see the Q&A window, there's some links there. We may just post them up. When we share around the recording, we can share around those links as well. And Alan and Freya, if you want to add any more to that, let me know afterwards, and we can share that with everyone.
Sure, will do.
So I have a question from Darius. At a high level, what data integration issues did you face, and how were they overcome? And was there a range of software that we used?
Freya, that's probably for you.
Yeah, I'm having a think. So specifically in the risk assessment work, there's different travel data sets, I suppose. They were broadly consistent. There's always different sources of information for reported cases, and trying to understand, and this comes back to some of the, I guess, testing practices question as well around whether they represent which data sets best represent what's a consistent testing practice and things like that. I guess for that bit of work, there wasn't any data integration. It's something that we do consider for other bits of work that we're doing now, and so like for the nowcasting and forecasting work, and then also thinking about different, so we might get estimates of R0, for example, from different types of studies, and we certainly have sort of, think about things like Bayesian evidence synthesis and those type of data integration methods. You can also, so sort of data integrating models are an important part of epidemiological modelling, because we do get estimates from different types of studies, and it's not always clear how they should fit together, but they might all be useful for trying to estimate the same latent variables, for example.
Yeah, I understand from James that for example, one of the issues is around trying to estimate the effective reproductive ratio with very scarce data, but something that might be factored into a prior would be other data from Google and Apple about how much people are moving. So if there's signs that there's a loss of adherence to social distancing measures that might show up in some other data set, might that be able to be integrated into that information be able to be integrated into estimates of R?
Yeah, that's actually a really good point, Alan. I wasn't thinking about that as data integration, but yes, we're certainly sharing information across different data sources too, and that's a good example of something we're working on at the moment. And also, a range of different mobility metrics as well.
So you can see we've already ticked over 6 p.m, but there's plenty of questions. So I think we'll just keep going with a few more, and then we'll wrap up to allow Alan and Freya to get on with their important modelling. So as long as you're happy to go up until about 10 past, we can keep going. But let me know if you need to leave, Alan and Freya. The next question is from Daniel. Alan, as an ID and public health physician, what would you advise your family, friends, and close relatives on return to normality if isolation measures are eased up? Stay at home or follow government guidance?
Look, I think it really depends on, government guidance is always very necessarily broad and trying to apply to the whole community. You really need to sort of look at that through the lens of your own family. So as an example, I have young children and elderly parents, and my parents are pretty old and frail, and I really would try and keep them isolated as much as possible, but trying to interact them as much as possible through other ways, like trying to get my parents onto Zoom is pretty difficult, but I'm trying to do that. And then for, my kids are young, they're probably about as non-susceptible to this infection as anything else. So if schools go back, they'll certainly be happy to let them go back. So it is sort of looking at your own situation and doing your own risk assessments based on your own personal circumstances.
We have a question from Pete. Assuming that the situation in Australia remains as is, when and how will we help the Asia Pacific region countries with their responses?
From a modelling perspective, there's been lots of teams actually around the country helping the countries in the Asia Pacific region with their preparedness, so their planning scenarios and risk assessment and various other things. I'm not across all of those projects, but so we did some work in February for DFAT and other groups, and there's also lots of work with Australian institutions through the Western Pacific regional WHO office as well. So that work has been happening from very early on, and I'm sure there's lots of other efforts that are outside of modelling too.
Yeah, I think there's clearly a lot of assistance that Australia will need to give. I think the most important thing is if Australia and New Zealand have relatively controlled outbreaks, that does protect the Pacific to some extent. But a lot of Pacific Island countries have very fragile health systems, and Australia does have, for example, OSMAD assistance that was given to, for example, Samoa for their measles outbreak, and I have no doubt that there will be assistance that will be required for Pacific Island countries and East Timor and Papua New Guinea as well.
Thanks. So we've got time for one last question. So this one comes from Alexander, who says, excellent talks. This question is for Freya. Just regarding your model from source to intermediate countries to Australia, did your modeling approach change when China was no longer the epicenter of the epidemic? For example, did you then treat Europe or the US as the source?
We stopped using this framework. It was only applicable when there was one source of the outbreak, and in particular that the risk to Australia was indirect, so not directly via that source. So yeah, exactly. We had to change our approach completely.
Freya, do you think that a broader model could be used?
Yeah, definitely. I think the thing is, so you'd have to. I think it was specific to our situation and the response measures we'd already implemented in having that travel ban implemented early, and then also thinking about our region and how connected we were and the possibility of undetected outbreaks occurring. But yeah, so definitely, and people have definitely developed more complex models that think about, so we have collaborators at James Cook University in Queensland who've developed more complex models that think about transmission as well between countries with global networks of transmission, and think about how something might spread and from country to country, and not just thinking about these discrete, I guess, transmission chains. Yeah.